presentation will be different from the previous two. It will be more concerned with...
Accidentally switched off the microphone.
It's okay? Okay. First of all, happy to see you here and to be also one of the presenters during today's session. I just wanted to say that my presentation is a bit different from the previous two when they were presented some very, very interesting, I think useful, I'm sure useful for the therapy scale or inventory. My presentation was concerned with patients who had hypochondria and how we can help them as we are cognitive behavioral therapists. So mainly it will be presentation of some cognitive model with some behavioral also aspects regarding to the problem which we call anxiety about the health or hypochondria. Here's a brief outline. So after some maybe short introductory part and definition, trying to define the hypochondria problem from the cognitive point of view, I will concentrate more with kind of elements, the obligatory elements, which usually are very, very important in the cognitive behavioral therapy. Before, just as an introductory part, to know maybe more to feel how the hypochondriacs can feel better, we can just remember some situations when we were worried about some injury or about some planning surgery as for us or our relatives. So if we analyze it, of course, it's related mainly to the anxiety, maybe a little bit to some OCD symptoms. So usually if we deal with hypochondriacs, patients with hypochondria, usually they refuse to have, at the beginning, right, psychological help. They say we are not, it's not our imagination really this sick, we have really disease, somatic one, and we are not just hypochondriacs. At the beginning, just few numbers, like statistic data regarding the hypochondria taken from different sources. So as you can see, there are different numbers of the percentage and different kind of criteria of the analysis who can be related to the prevalence of the hypochondria in the population in general. Some sources are given like 3 to 13% of hypochondriacs, or who worried about the disease like 10-20%. We can talk about for example, Baski and Clermont have nice results from 30 to 80%. Patients who consult the doctors, usually their syndromes, their somatic syndromes has no basement. Or we can talk about other ideas like women are more kind of, has more predisposition, has a high predisposition to meet the criteria for somatization. And we can talk about some age, like early adulthood, as a peak incidence of the hypochondria occurrence. As I told at the beginning, usually hypochondria is related to so-called anxiety disorders or to OCD disorder. So firstly, it was usually interpreted as kind of secondary to depression and anxiety problem. But of course, now we are talking about the separate place in the classification of the disorders, when we can talk about the severe persistent anxiety focused on the health. So here I just mentioned what I found in different sources, the relationship between hypochondria or the co-occurrence of hypochondria and other problems, other diseases, disorders. So we can talk about depression, about the OCD panic disorder, first of all, and mainly the cognitive model of hypochondria is concerned with the panic disorder and OCD model. Here just some criteria. I'm sure some of you maybe met it, like knows about it. I just mentioned a few of them. So of course we are talking about the excessive focus on the anxiety, which usually associated with a conventional serious illness based on the interpretation of bodily symptoms. Still, patient usually is concentrated with its interpretation, even if there is lack of improvement of medical evidences. Usually it should be last at least 6 months, and it shouldn't be caused by a somatic disease or some psychoactive substances. And of course it influences significantly on the patient and his community life. What is important from cognitive point of view? So usually we are concentrated with so-called misinterpretation of different symptoms, so-called somatic symptoms, which usually is related to the very, very high severe anxiety or worrying about the health. And also it's related to some so-called safety behaviors. It's usually kind of a little bit compulsions maybe, which helps patients to feel better after acting in some specific way. Just a few words. If you're talking about the cognitive behavioral therapy, we are talking about kind of short therapy, when usually we have like around 12 meetings, so it's not enough time maybe to work very, very deeply on all the problems patient has, because usually hypochondria, it's like the main one or the secondary one. It depends on each case. But what is important here that usually we are concentrated and focused with a very, very deep engagement and involvement of the patient in the therapy. So the patient should understand the whole model of the cognitive behavior and really, really actively participate from the first stage when we formulate the goals and finishing with a, for example, relapse prevention plan. Here just the main assumptions which usually in cognitive therapy are very important. So of course we concentrate with the bodily or with somatic symptoms which usually perceived by the patient as more dangerous than it is in the real life. The same deals with some disease which is perceived as more serious, but in real life it's not so serious as it should be. And of course patients have some idea that they're trying to solve their problem, but the way of reassurance seeking is not so efficient in this case, so finally they kind of agreed to have the psychotherapy. Here are just some key features which are very important to concentrate with. So first of all, talking about the misinterpretation of the bodily symptoms and some information which comes from the doctors. Then concentration with reassurance seeking from kind of two sides. On the one hand, usually they want this reassurance that they really have some problems, some physical disease, but on the other hand, they don't perceive and don't accept some reassurance. They kind of ignore just some of them. Here I have just some examples of just taken from some case studies. So if you have like head tracing or bounded palpitations, so usually patients interpret it as a head attack. Either some lumps under the skin, cancer 100%. Either some dizziness, heart pounding, or whatever other palpitations, very, very high. So usually they interpret it as immediately heart attack and dying. Okay. Let's see. As I said before, right? So it's usually the therapy based on the very high level of cooperation between the patient and the therapy. So that's why it's really important from the very beginning to not define what problem is not, but kind of find what problem is in real life. So really, it's really important to find some common understanding of the goals of the therapy and of the problem, like especially the kind of background of the problem or the psychological basis of the problem which this exactly patient has. And of course, there are a lot of activities, there are a lot of kind of during the session, outside the session activities, so the patients really should feel very much engaged and involved in this process. And one of the objectives is very important when we have to find some alternative ways to cope, of coping with the problems, with the interpretation of this somatic symptoms in a little bit different way than usually a patient used to do it. There are a few elements in the cognitive therapy, in cognitive behavioral therapy. Of course, one is kind of cognitive one, so it's usually kind of questioning of the beliefs and assumptions, which are especially the dysfunctional one. Also, it's trying to change or to modify some behaviors, which could be one of the maintenance factors of the problem. So maintenance factors is really important part of the cognitive behavioral therapy. And we can distinguish like three types, or we can analyze it into the so-called research flowers, different kind of relationship between all of the elements which are included in the so-called case formulation. So we can talk about behavioral, cognitive, and somatic or physiological maintenance factors. I had it somewhere in the, yeah. Like if you have some problems, so we are trying to understand how the patient sees this problem, not how we are. Not how the book says, how we have interpreted. So usually we are taking just some part of the so-called formulation and like a little bit maybe playing with this, certain arguments for and against, doing different experiments, which also can a little bit questioning the safety behaviors efficiency in this case. Like here, there are a few examples of so-called maintenance factors when, for example, misinterpretation of the symptoms, somatic symptoms usually also increase the focus into the problem, and of course it maintains the problem and believe that really the patient has so-called physical problem or disease. The selected information just focusing on what prove the hypothesis or expectations of the patients also usually maintain in the problem because it's combined also with the emotion part and this so-called cognitive part when it's talking about the thoughts related to the negative thoughts related to some disease or somatic problems, and usually it's also a kind of supporting or maintaining the believing in the existing problem. Other behaviors, kind of safety behaviors like avoidance, checking, reassurance seeking, also usually support the belief of the patient in having some illness. Here are some just main elements. There are more, of course, which used. I just choose some the most maybe important from the hypochondria point of view. So there are a lot of different inventory used. Probably the PVI also can be useful in this case. But the most usually useful, of course, the scales or inventory related to the anxiety measurement or sometimes some compulsions and depression. Self-monitoring usually it's kind of during the whole process of the therapy is a very important element of the therapy, especially if you want to prepare the patient at the end to be kind of independent from the therapist, to solve the problems and the situation by oneself later and not coming all the time to the therapy. That we can talk about the cognitive part like beliefs, assumptions, thought, especially dysfunctional one, questioning. It's also related to creating some alternative so-called beliefs, thoughts, and assumptions also. Very important part is so-called behavior experiments. Usually patients don't want to be involved in it, so with big enthusiasm, but usually the most helpful method or tool which we can use and by which we can help the patients. And the kind of second part may be usually considered the therapy related to the rumination, word and images work. So when we usually want to kind of a little bit show that this activity, this way of thinking is usually only kind of maintaining the problem but not helping solving this. Then the work with so-called persistent reassurance is very, very important. It's really also related to so-called medical consultation. It's sometimes not so easy to kind of start therapy when the patient is still seeking very, very actively for medical, evidences of improvement which can help for patients, kind of help to solve the problems. And the last one is very, very important part is relapse prevention. I have time, right? Okay, maybe a little bit shortly. If you're talking about assessment, so usually we use different tools. It could be kind of standardized one, or it could be just created for the situation based on some cognitive models, which are really effective one because usually it gives some information, knowledge about the trigger mechanism, about the kind of causes of why the person still has this problem, why the problem, for example, become increased in some moments. So usually it helps to make the deeper the so-called formulation of the case, and for the patient and for the therapist, of course. It gives more information for the therapist, kind of understanding the problem, the roots of the problem, but from the way of the patient, usually he or she feels more kind of understanding, and usually it's also influenced very positively on the next stage when we want to, for example, implement the behavioral experiment. And what is very important in assessment, it gives kind of background for the patient to at least consider some other ways, not only catastrophic one of the interpretation of the bodily symptoms, or just try other maybe strategies which could be more efficient but begin too frightening for the patient. For the self-monitoring, we can use different tools, and usually we use different. It could be scaling, it could be pie chart. It depends on the situation and on the kind of cooperation with the patient. Here I have one example, so-called vicious flowers, when the patient can just trying to understand what happened, really what is the problem, what is the trouble, what it means to this patient, what happened with the body, with behavior, and with some kind of emotional state. And usually we can choose also later one of these parts just for doing some behavioral experiments later on. Also, it could be done not only in the vicious flowers style, but also we can use different tables. But the main idea of the self-monitoring just to put together everything, like the trigger mechanism or the trigger causes, the situation that happens, and to relate it with the emotion state, with the mood, with the somatic symptoms, and of course with the behavior. Question beliefs is really important part. It's actually analysis of beliefs, of thoughts, and of assumption is doing all the time during the whole therapy process. But what is like it's common for other anxiety disorders or other disorders which cognitive behavioral therapies could help with. But what is important here, for example, so-called pyramid technique can be used when we are trying to show the patient that the number of people who just worried about their health and the number of people who really can have troubles because of the health kind of death or other negative consequences of bad treatment. So the numbers are really, really very different, like extremely different. So usually this technique, the other rational technique would be useful to show the patient that the way how they functioning, I mean a cognitive way, is not so functional one. Okay. And one of the favorite parts of the work, like cognitive behavioral therapies, is planning and conducting and then analysis, of course, of the behavioral experiments. It's sometimes not easy to persuade patients to participate in it, but really it gives a really good result. The one important thing that should be really planned very, very carefully, step by step, what can happen, what we kind of assume can happen, and kind of scenario another one, if not, right? How we can interpret it if what patient expects will not happen. And for example, there's a very good experiment which can do everybody actually, like I have here, right? So if you try to concentrate with some part of our body, like I give here, if you can think about your big finger on your left foot, whatever, and concentrate for 1 minute how it feels. I'm sure that sometimes you start feeling this finger. So now we don't think about it at all, but in some time, of course, we'll be considering how it is it comfortable, is everything okay? Right, it's like kind of one of the experiments, so-called selective attention experiment, one of the times, which usually show that our concentrating so-called selective attention to some parts of functioning usually causes and maintaining the problem and the interpretation of it. Important also could be so-called test and prediction experiments when we assume that it depends, of course, on the problem. When the patient thinks that probably heart attack could happen to him or to her, so we can run stairs or do other things, the other exercises, and just check if it also influences on our body feelings, and of course after that what we think about it and how do we feel with that, and if it also influences on the kind of safety behaviors existed and maintaining the problems in general. One of the good type of experiments could be drop-in safety-seeking behaviors. When we know what are the behaviors, so-called safety behaviors of the patient, so we are trying to persuade patients during one day just to use it as much as it's possible and to find out if it's really, really helpful one. Of course, next day, the patient is trying not to use any. It's very difficult. So usually the help of the family or friends is really, really important in the type of the experiment. But actually, if I talk about the behavior experiment, there are a lot of positive influence on the therapy course in general and on the change of some like so-called cognitive reconstruction. Some of them just listed here. So first of all, the patient can notice from the real life that really what we believe it's not the truth. So we maybe have to distinguish sometimes belief from facts. The patient can understand that catastrophic interpretation is not the only one, it's not the only true one, so there could be some other alternative one. Also, we can just discover the importance of some maintenance factors, negative thinking, negative thought, assumptions, and so on. Like here, there are different safety, so-called safety behavior when we pay more attention to the problem. When we trying to go to the doctor, we need to find out if I'm sick, if I really have this problem and other things. So we can just choose one of the safety behaviors and just plan the experiment, but usually this should be the most important behavior. A very important thing is very difficult when we are working with the medical reassurance because patients don't want to stop it. It's kind of giving them really feeling of safety. So sometimes even it's not recommended to start the therapy until the patients will not stop or at least decrease the number of visits of the doctors. Also important thing sometimes because in cognitive behavioral therapy usually we record the sessions, and it's really, really important, useful thing when you want to kind of prove later some changes or some beliefs of the patient, so you can just give to hear it. Because usually if there is some improvement, some change, they deny it sometimes, that I didn't say it, I didn't believe in it all day, but the therapy doesn't help at all. So I really have to back to the medical reassurance. So the recording analysis is really, really important in this case. If you're talking about the rumination topic, worry, and work with images, rumination and worry, it could be also very useful when we give some time, and patient can ruminate as much as he or she can. The same is the worrying, but we should kind of a little bit take a guarantee from the patient. Okay, you ruminate, you're sure it's very helpful, so take your time, ruminate as much as you can, but at the end you should be guaranteed that it's enough for you, for example, for 1 month. After that, you will not start the rumination or worrying. It also shows patients that it doesn't work, actually. It also kind of increase the problem and influence negatively on the way how the patient feels. And with the images, of course, it works like when we can use different types of visualization, or just to finish the images according to the patient how want to be, or how, for example, this kind of positive scenario demands to be. Actually, I mentioned about this reassurance seeking also before. Only what is very important, usually reassurance is one of the most important part of the formulation. So usually we use and we kind of update the formulation all the time, is all the factions which we took from each session. So usually it also could be used, the formulation, kind of the example for to show the patient that this reassurance seeking is not so a successful one, and so needed for him. And the last one, usually it's an important part before the ending of the therapy, when we have to be sure that the patient can cope with the problem later on just by him or herself. Actually, we start working on this process kind of from the very beginning when we're starting to formulate the goals. So at the end, usually the patient's kind of a little bit sure and predict that this plan should be created. And usually in this relapse prevention plan should be included everything, like starting from the skills which the patient gained during the whole therapy, what learned, what can do by himself, and so on. Also, there should be different analysis of different situations that can cause kind of relapse of hypochondria later. And also there should be plan of coping with it by the patient himself. It's the most maybe important thing. And of course, it's very important to persuade the patient just to feel really, to feel importantness of this relapse prevention plan for the future. And just to finish with, there are just some examples of the studies which can show the effectiveness of CBT. Of course, it's kind of sometimes taken from the context, but still it shows somehow that work with cognition and the behavior could be effective if you're talking with the hypochondria, especially if you talk about the diseases with somatic symptoms, or if you're talking about the comparison with the family therapy, just medical treatment, or for example, group therapy also. Okay. Thank you so much. I finished.